Understanding heart disease. The purpose of this education session is to gain a basic understanding of the heart structure and how the coronary artery disease process occurs. We will cover some anatomy and physiology, explain what coronary heart disease is and why it happens, and finally some of the treatments you may have heard of or experienced yourself. The human heart is located in the centre of your chest and is approximately the size of your fist. It is a double pump that is vital for delivering oxygenated blood to your whole body. Firstly, let's take a look at the internal structure of the heart. As you can see from this cross-section, the heart is made up of 4 chambers, separated by valves. The valves are important in keeping blood flow through the heart one way, separating deoxygenated blood on the right side, represented in blue, from oxygenated blood on the left, represented in red. Deoxygenated blood from the body enters the right atrium, then the right ventricle, and is pumped out of the heart via the pulmonary artery to the lungs, where red blood cells pick up oxygen. The blood then flows back into the heart via the left atrium, then left ventricle, and is pumped out of the aorta to the rest of the body. You will notice that the muscular wall of the left ventricle is significantly thicker than the right. This is due to its need to pump blood to the whole body, whereas the right ventricle only needs to pump the short distance to the lungs. There are 4 valves within the heart which, as mentioned previously, keep the blood flow one way. A heart valve is a leaflet-type structure that opens and closes freely and tightly with each heart contraction. On the right side of the heart there are the tricuspid and pulmonary valves, and on the left we have the mitral and aortic valves. As the left side of the heart is under considerably more pressure, it is more common for problems to occur with the mitral or aortic valve. Valves can either become stenosed, meaning stiff and rigid, or weak and floppy. Both of these eventualities can end in ineffective opening and closing of the valves, interfering with the one-way flow of blood through the heart. When we get backflow or regurgitation of blood due to ineffective valves, the oxygenated blood can become diluted by deoxygenated blood, which, due to the decrease in amount of oxygen reaching the heart muscle, can cause shortness of breath and fatigue. Valve disease, once diagnosed, is often monitored over a period of years by a cardiologist. If over time symptoms worsen or your doctor feels the valve is severely damaged, they may recommend surgery to repair or replace it. If it is replaced, the valve may be mechanical or tissue. The next element of the heart structure that is useful to explain is the electrical system. The heart's electricity is generated from a cluster of specialized cardiac cells called the sinoatrial node. This is the heart's natural pacemaker. Impulses generated here are received by the atrioventricular node, located in the right atrium, and then filtered down the conductive fibers that reach around the right and left ventricles. This impulse causes a contraction of muscle, which in normal sinus rhythm will be even and regular. There are many abnormalities that can occur within the heart's complex electrical system. Some you may have heard of during your patient journey include left or right bundle branch blocks and atrial fibrillation. Bundle branch blocks can occur when some cardiac muscle has been damaged due to a heart attack. And atrial fibrillation, or AF as it's known, can cause an irregular heartbeat. There are many causes of atrial fibrillation, such as age, alcohol, infection, and cardiac disease. And if left unmonitored or untreated, can cause a mini stroke or stroke. It is a good idea to check your pulse regularly, or if you're experiencing any palpitations. It should be even and regular over a 1 minute period, and at rest approximately 60 to 90 beats per minute. Occasional missed beats are completely normal. If you find your pulse irregular or fast at rest, contact your GP or accident and emergency if you are feeling unwell. To feel your pulse, use your opposite index finger to palpate your pulse on your wrist at the base of your thumb. Count the number of pulses you feel in a 1 minute period. This will give you your heart rate in beats per minute. Now to explore the heart's blood supply, the coronary arteries. These blood vessels branch off of the aorta and sit on the outside of the heart muscle, supplying it with blood and oxygen. There are 3 main coronary arteries. One on the right, represented by number 2 on the diagram, is your right coronary artery, or RCA, and 2 on the left. The left anterior descending artery, or LAD, is shown by number 3, and the left circumflex artery that wraps around the back of the heart is shown by number 4. When we talk about heart disease, it is these vessels we are referring to. You may hear other terms such as coronary heart disease, coronary artery disease, or plaque disease, which all refer to the same thing. This next slide shows the main coronary arteries, the RCA, the LAD, and the left circumflex, along with the other branches that feed all areas of heart muscle. So what is coronary artery disease? Put simply, coronary artery disease is a build-up of fatty deposits within the coronary arteries. This is made up from excess fat, cholesterol, calcium deposits, and other substances found in the blood. It is commonly known as plaque. Over time, plaque can narrow and harden your arteries and cause problems with blood flow and supply of oxygen to the heart muscle. This slide shows a real-life representation of coronary artery narrowing due to plaque. Note the excess fat surrounding the artery also. This slide shows a cross-section view. The artery lumen should be whole and round, but the blackened areas of plaque would have been limiting blood flow. The plaque does not necessarily collect in a single area. This CT scan shows many areas of disease within the arteries. We call this diffuse disease. To understand coronary artery disease further, it may be useful to firstly look at the arterial system as a whole. Plaque can build up in any artery of the body, but it's the diameter of these vessels that can cause difficulties. As you can see in this diagram, the arteries in the body's trunk are much larger, so build-up of fatty plaque tends to be less problematic. It is the areas that have small vessels, such as the brain, penis and heart, that experience the effects of the disease. The umbrella term for plaque disease within the arteries of the body is called cardiovascular disease, and, depending on where the disease occurs, influence the clinical event. This table shows the location of the artery, its diameter, and the possible consequence of plaque disease. If plaque occurs in the arteries of the penis, it may manifest as erectile dysfunction. In the coronary arteries, it may cause angina or heart attack. In the carotid arteries, a TIA or transient ischemic attack or stroke, and the femoral arteries may cause claudication, otherwise known as peripheral vascular disease. It is important to remember this during your cardiac rehabilitation, as the advice given aims to protect against all of the above conditions. Before we move on, I would just like to take this opportunity to briefly mention erectile dysfunction in the context of coronary artery disease. As we have just learnt, plaque disease can affect your whole body. So, if you are male and have been diagnosed with coronary artery disease, i.e. you've had angina or a heart attack, there is a chance the arteries of the penis are also narrowed and may cause impotence, the inability to get or maintain an erection. Adhering to lifestyle advice during the cardiac disease risk management program may slow progression of this or prevent it altogether. If this is something that is concerning you, please speak to your cardiac nurses or GP for advice. Please also note some cardiac medications may cause or worsen erectile dysfunction, which is also something you should discuss if suspected. We now move on to discuss the possible consequences of coronary artery disease, namely angina and heart attack. If we think back to this slide showing plaque buildup in the coronary artery, we can now explain how this causes the symptom of angina. Put simply, angina is chest pain or breathlessness caused by a reduced blood flow to the heart muscle. In order to function effectively, the heart muscle needs good blood supply. A plaque or narrowing in the artery causes a bottleneck, so the balance between oxygen supply and demand is affected. The most common characteristics of angina are a feeling of pressure or constriction. It is often brought on by physical activity or emotional stress. You may feel short of breath, and it's often very similar to feelings of indigestion. Generally, angina will ease when the demand for oxygen decreases, i.e. stopping the physical activity you are doing or relaxing from emotional stress. It will be relieved by GTN spray, as this drug widens the blood vessel to allow more blood to flow through. Angina is most commonly associated with pain in the chest. However, it can actually be felt in many different areas of the body, such as the chin or jaw, shoulder, back, and wrists. Some people do not experience it as pain at all, just a discomfort, breathlessness, or fatigue. It is now time to distinguish the difference between angina and a heart attack, otherwise known as a myocardial infarction. We will cover how and why a heart attack occurs, what symptoms to look out for, and what you should do. The disease process for a heart attack is exactly the same, in that plaque forms within the lumen of a coronary artery. The distinguishing feature of a heart attack over angina is the spontaneous rupture of this plaque. The fatty material of the plaque is covered by a fibrous cap, holding it in its position on the artery wall. If this cap ruptures, the fatty deposits spill out into the heart artery through the tear. The body recognizes this as an injury and quickly forms a blood clot to plug the rupture. This is a heart attack. Unfortunately, this blood clot can block the small, delicate coronary artery, either fully or partially, and significantly reduce or stop blood flow. This occlusion causes lack of oxygen to the heart muscle, known as ischemia, and if not treated quickly, can cause irreversible damage to the cardiac muscle. We can categorize heart attacks into two types: non-ST elevation myocardial infarction, or to abbreviate, non-STEMI, and ST elevation myocardial infarction, or STEMI. The naming refers to its presentation on an ECG rather than the seriousness of the event. Non-STEMI generally refers to a partial or intermittent blockage of a coronary artery, and STEMI refers to a complete occlusion. Both can have equally good and poor outcomes depending on treatment, territory of the heart attack, and comorbidities of the patient. The grey area on this diagram represents the area of muscle beyond an occlusion, which may be damaged as a consequence of a heart attack. If you have had a heart attack, you would most likely have been started on an ACE inhibitor such as ramipril, which is a drug that helps prevent left ventricular remodeling after your event. What this means is that some of the damage to the heart muscle may be reversed and some of its pump function returned. This is sometimes observed during an echocardiogram if considered clinically necessary. It is important that your GP increases your dose of ACE inhibitor to as high as your blood pressure will tolerate to gain maximum effect from this. More information on this can be found in the medications presentation or from your cardiac disease risk management nurse. Symptoms of a heart attack are sometimes similar to angina, but are often more severe and associated with feeling unwell. You may feel clammy, cold and sweaty, short of breath, dizzy or lightheaded. It is common to feel nauseous or vomit and have feelings similar to indigestion. Many patients experience often severe central chest pain. However, it is important to recognize this is not always the case. Many heart attacks can be pain-free or silent, especially in those patients with diabetes. So what should you do if you suspect you or someone you know is having a heart attack? Firstly, call 999. This is to ensure professional help is on the way with appropriate drugs available, and to keep other road users safe by not driving your car. It would also not be sensible to get someone to drive you, as your condition may deteriorate along the way. Ambulance crews are able to forward ECG tracings directly to the cardiologist at your local hospital from your home or other location, so going via accident and emergency may slow this process. Those that have had an ST elevation myocardial infarction or STEMI would have experienced this firsthand by being transferred directly to the cardiac catheter lab for primary PCI treatment. Sit down and try to stay calm if possible to reduce your body's demand for oxygen. If you have been issued a GTN spray, use it as per instructions. We would not advise you borrow another person's spray if offered, as it can have short-term effects on your blood pressure. Not all chest pain is cardiac in nature. There are many other causes of chest pain which can feel rather similar to cardiac pain, so this checklist may help you to rule things out. Indigestion is commonly confused with cardiac pain. Ask yourself whether you've had a big meal recently. Have you eaten spicy, acidic or unusual food? Is it relieved with antacids? Anxiety can cause chest pain. Ask yourself if you're feeling particularly stressed or under any emotional strain. Do relaxation or mindfulness techniques help? Pulled muscles and joints. This may occur due to a hospital stay, following cardiac surgery, or during your phased return to exercise. See if your pain is relieved by paracetamol. And chest infections. Do you have any other viral symptoms such as a cough or cold? If so, it may be chest pain from an infection of the lungs that sit very closely to the heart. There are several different treatments for coronary artery disease: clot busters, angioplasty, surgery, and medication. Clot-busting drugs aim to disperse the clot blocking the artery during a heart attack to allow blood to flow. It is a very effective treatment and was widely used prior to the mainstream use of angioplasty. It is now generally only used in remote areas that do not have quick access to angioplasty, which is the current gold standard treatment for heart attacks. Angioplasty, otherwise known as percutaneous coronary intervention, is a procedure to unblock a coronary artery. A balloon-tipped catheter is advanced to the blocked artery and inflated, expanding a stent to the artery wall. A stent is a small metal scaffold that remains in the artery once the balloon has deflated to support it and keep it open over time. A question we are commonly asked is how long do stents last? There is no definitive answer to this. However, if stents are well looked after by following lifestyle advice from your cardiac disease risk management program, they can last for many years. If poor lifestyle choices such as smoking, excess alcohol and high-fat diet continue, the artery may restenose or reclose over time. There are also some unfortunate circumstances when restenosis occurs despite following all the advice given. This is rare and can be treated if it occurred. In some patients, angioplasty is not the most suitable treatment option, and you may have been referred for a coronary artery bypass graft. This is a surgical procedure which replaces the diseased artery with healthy vein or artery tissue harvested from the patient's own arm or leg. Looking at the left-hand side of the diagram as you view it, you can see how the harvested vessel is stitched either side of the diseased artery, literally bypassing it, hence the name. Looking at the right-hand side of the diagram as you view it, you can see another type of graft using the left internal mammary artery, which is snipped at one end and used to bypass disease in the left anterior descending artery. Blood will flow through the route of least resistance, which will of course be the new vessel, and the native vessel will close up over time. Bypass grafting is often the most appropriate treatment if there is disease in 2 or more coronary arteries, the patient has diabetes, or the plaque buildup is on a branch or junction, making angioplasty impossible or unsafe.